Hello everyone, it's World Endometriosis Day, and I would like to welcome all of our viewers from across the globe to the 2023 Endometriosis Australia Symposium for Endo March. My name's Hertz and I'm a proud supporter of Endometriosis Australia, and I look forward to bringing you the wonderful lineup of guests we have with us here today. We would love to start by acknowledging the traditional owners of country and recognise the continuing connection to the many lands, waters and communities we meet on today. We pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past, present and emerging. To commence our symposium, I would love to introduce to you Endometriosis Australia's Medical Director, Associate Professor Anusch Yazdani. He's a subspecialist in reproductive endocrinology and infertility, and an advanced reproductive endosurgeon with a uniquely personal and patient-centric approach. As a leader in surgery and reproductive endocrinology, Professor Yazdani is the Program Director for both Queensland Reproductive Endocrinology and Infertility and Advanced Endoscopic Surgery Specialist Training Programs. He is also widely published and lectures nationally and internationally. Please make very welcome Associate Professor Anusch Yazdani to the symposium.
Thank you, Candy. On behalf of Endometriosis Australia, welcome to our 2023 symposium. My name is Anusch Yazdani and I'm the Medical Director for Endometriosis Australia. Endometriosis affects approximately 1 in 9 women, girls, and those assigned female at birth. So that's close to 1 million women in Australia. Yet it remains painfully underdiagnosed, under-researched, and undertreated. In 2023, Endometriosis Australia is celebrating its 10th birthday. Our organisation advocates for those impacted by this disease, providing education and raising funds for research into the causes, diagnosis and treatment of endometriosis. In fact, even though we're a not-for-profit organisation, we are the largest single source of dedicated endometriosis research funding in Australia and New Zealand, and you will hear about this amazing research from our panel members today. Our activities like this symposium raise awareness and advocate for better research, education and support for those affected. Through these activities, we can break the silence to ensure that people with endometriosis receive the care and resources they need to live healthy and fulfilling lives. So, enough from me, and let me hand you back to Candy to introduce our panel for today.
Welcome back everyone. I hope you found Associate Professor Anusch Yazdani as insightful and uplifting as I did. Next, I'm excited to say that we have our panel Q&A. These researchers and endometriosis panellists have been selected from across Australia to highlight some of the groundbreaking research currently underway across the country and to gain their perspectives on how research plays such a critical role in improving patient care and outcomes. I would like to welcome our panellists today. I'm excited to say that I'm joined by Professor Louise Hull, obstetrician and gynecologist and group leader of the Endometriosis Research Group at the Robinson Research Institute, University of Adelaide from South Australia. Next, we have Dr. Kate Tyson, gynecologist, advanced laparoscopic surgeon, obstetrician, ages, and director of the Julia Argyrou Endometriosis Centre at Epworth. Please also make very welcome Antara Mascarenas, an executive in the renewable energy sector, an Endometriosis Australia ambassador, and an endo warrior. And please welcome our Professor Caroline Gargett, Research Group Head, Endometriosis Stem Cell Biology at Monash University. And last, but certainly not least, we have Dr. Brett McKinnon, Research Fellow, Institute for Molecular Bioscience at the University of Queensland. Welcome to everyone. I'd like to start with Professor Louise Hull. Professor Hull, you've been excelling in the field of fertility for many years. Was it something that you were seeing in your patients in the clinic that sparked that interest to invest more of your time into endometriosis research?
When I was started in ONG, it was in the late 90s. And actually, we really didn't know very much about endometriosis at all. And we certainly didn't understand the pain pathways. We didn't understand its etiology. We didn't have any markers. We had very poor diagnostics and really not very good treatments. And so it was actually a very a big black hole from the medical perspective. So it was something that very, very few people knew about. And I actually was doing some training in the UK and had the opportunity to do a PhD there at Cambridge University, where they had a project being developed with the very, very newest microarray technology looking at the molecular basis. And in actual fact, the O&G department in that department was very ahead of all the other specialties in terms of wanting to find something out about endo, which we really couldn't figure out how to find a pathway through. So we ended up doing some of the very first arrays, looking at the lesions and comparing them to the endometrium and trying to find markers for diagnostics and markers for treatment. And the very satisfying thing about the career is basically using all that really novel digital technology and working out, we used to get a lot of data, but we didn't know what it meant at all. And we had to actually develop ways of reading it to make biological sense. And that was such a creative, fascinating project with the Cambridge Maths department. And we found all these markers, and it sort of, once I knew the markers, it was like, well, how do we now change things for women? That, you know, we've now got at least some understanding of what the biology is. So it was really fortunate because we really got some very, very interesting new things. And at that point in time, I was quite young. I didn't realize that would suddenly go for the rest of my life, or rest of my working life anyway, to developing more and more new things. But we had so much potential because we just knew nothing much. We did a lot of surgery and we had some medical treatments, but we really it was very clear there was a massive need and we didn't even have a handle on the biology there. So, I was sort of there right at the beginning. O&G's obstetrics and gynecology. So it's to do with reproductive health and things like gynecological conditions to do with the uterus or the endometrium or the ovaries, and conception and pregnancy. So it's the people who specialise that. Obstetrics is really looking at pregnancy and delivery. Gynecology is looking after the health of those reproductive organs to ensure they work properly and don't create other problems like pain and bleeding.
Fantastic. Now, you led a brilliant research project called Imagendo, which received an Endometriosis Australia grant in 2020 and then went on to be funded by the federal government for $1.9 million. That is absolutely incredible. Can you tell us a little bit about this project and what you learnt through your findings?
What we did, we actually did a very large review of all the diagnostic tests that were available for endo other than surgery. And we really wanted to find a way that women wouldn't have to go to surgery to get a diagnosis. And we literally had 15,000 papers of people who had tried to find markers. And when we did that study, it was very clear that the things that we could actually get a diagnostic potential from were based on lesions. They were either seeing the lesions or imaging the lesions. But the other biological markers were generally inflammatory, and a lot of different conditions in your body create similar markers. So we really were finding the imaging was really important. And having looked at all the digital data from the molecular side of things, my idea was we should be able to put the digital data from our ultrasounds and MRIs together to be able to give people a much better chance of actually getting a diagnosis. And so I was really lucky because we were starting to get better scanning, and I'll talk to that a little bit later. But at the same time as that was happening, I met a professor called Gustavo Carneiro, who was working in Adelaide, and his specialty was putting images together digitally and using artificial intelligence. And he had been doing that for quite a wee while and was really ahead of the field on artificial intelligence. But he also had a personal experience of endometriosis within his family. And he was very, very invested in helping people with endo at the same time. So we sat together and worked out things that we could do, and we realised we needed thousands and thousands of scans, and we needed to be able to improve the quality of the scans. So we devised a project where we could get lots and lots of scans and MRIs, and then look for the digital signatures in those scans to be able to give people the idea of you've got this much chance of having endo when you get to surgery, and hopefully being able to give a lot more people a diagnosis. At the same time, we wanted the sonographers to improve their scanning, and we are working on a feedback tool. So if they don't do a scan that images a diagnostic marker for endo, we can feed back to them at the time of the scan to get that image better, so that we can diagnose better as well, because an endometriosis scan is quite different from a standard scan, and a standard scan will not pick up endometriosis and it won't look for it. So we were hoping to improve the quality of scanning as well.
That's amazing. Now, I guess you hear this a lot, people saying they have all the symptoms for endometriosis, but nothing comes up in a scan. They get really deflated, feel a little lost for answers. What are some of the barriers to a quality scan for endometriosis? Can you just go to any ultrasound location and they'll know what to do? Or are people with endo just not getting referred to clinics with sonographers trained to look for endo?
The main thing is to get the right scan. And I mean, I work clinically as well. I see a lot of patients with endometriosis, and particularly people who have fertility concerns don't always have pain. And they may have been through lots of IVF or seen lots and lots of doctors, have had 5 or 6 scans that have been standard scans where you won't pick it up. And then we finally get a specific endometriosis scan. And, you know, people will burst into tears because since they were 15 years old, they've had pain and no one has been able to tell them what that was. And finally, they haven't had to have invasive surgery, which often they don't want. And particularly, you know, they may want different treatments. If you get the diagnosis, you've now got a choice. You can now explain it to your partner. You can explain it to your parents. You can explain it to your friends, to your employer. You know, it's so different if you know what it is, but also, you know, it's not cancer, you know, and you know, not everybody wants surgery, but they do want to know what's causing their symptoms. And a lot of people get told it's normal. And then they think they're going mad because they keep saying it's here, it's real, this is what my life is. And other, you know, they see health providers or other friends or family even, and they say, oh, it can't be. That's just what periods are. And they're like, well, I have to stay in bed for 2 days. That can't be true. And it isn't. You know, there's a biological cause. It's just our funding in women's health and gynecological problems has been so low that we haven't done the work to be able to get these answers. And luckily, we've had so much better funding since the National Action Plan. We're still miles behind. You know, gynecological scans are much more underfunded in Medicare than any other scan. And, you know, until there's a little bit more recognition that this affects 1 in 9 women, and the productivity and life outcomes in terms of missing education and missing work and not being able to participate in family events. And, you know, there's so many things that we could help if we actually recognized it as a condition and then thought, well, if we fund it properly, we can actually fix it. And when I started, it wasn't something that we thought we could treat. And now we would never think that.
Professor Hull, under the National Action Plan for Endometriosis, your team was appointed to create an online hub of information for patients, doctors and researchers. Now, it's called EndoZone and it's a great name. The project launched in March 2022 and has now been in the market for a year. Can you tell us a bit about the website and if you've uncovered anything that's informed changes for better patient care?
The EndoZone project is a way of digitally connecting people across Australia, and we're increasingly finding across the world. And what we wanted to do was to be able to provide information to people with endometriosis in a way that to answer the questions they had and a place they could go to find out information, but also to health providers and to researchers and other allied health professionals like physios and sonographers and radiologists. And we really wanted it to be, we were asked to make it a national platform. And as you know, we were able to engage all the 5 major endometriosis communities, including Endometriosis Australia, to actually sit, and for a year we asked people what they needed, what happened to them in their journey that would, that caused an issue, and what kind of things they thought we could do to help them overcome those issues. And the interesting thing of everything everyone talked about was they felt if they could improve the communication between doctors and patients who had endo, people would at least be able to go to the doctor and not be told it's normal, or, everybody gets pain, or, in a very short consultation, at least get the next steps, or at least be told, go to this website, have a read, try and look through, see if anything fits here. And one other aspect of the website is the health report. So what we found were young people found it quite intimidating to go to a doctor and talk about their periods and talk about their pain. And they often had a problem that would get sidetracked into all the other symptoms they had. So we developed something called the health report, which means we could just ask people what their symptoms were and give them some kind of idea of whether they should be seeing their doctor or whether they could try something more simple in the first instance. But then if they were going to their doctor, they could actually see what the questions were likely to be they were going to be asked. So it didn't put them on the back foot when somebody asked something that is relatively personal, when they got into the consultation, and they can actually hand the paper over. So they don't actually even have to verbalize it all. And that one of the big things was their main problem, so that it didn't get missed in trying to work out what was going on. But probably the other thing that's the most popular on that website is a video we have, and it's actually on the clinicians page, and it explains the pain. So everybody thought it was the lesions, and nobody could work out why the pain symptoms were so different between women and why they were in different places compared to the lesion. And what we know is that every time you have a period, when the tissue leaves your body from the normal endometrium, the lesions up in the pelvic cavity break down, and some of those dead cells generate an immune response. And that immune response brings white cells in that release all kinds of chemicals that then cause pain, and it causes inflammation. And it's like when you cut yourself, your hand will go red. And that happens if you have endo when you get a period. Now that trigger every single month ultimately activates a nerve in the back that then sensitizes all the organs. So you can have bowel pain or bladder pain or diarrhea or pain with intercourse, but then the muscles get sensitized too, and that's sharp stabbing or shooting pains, and that's really disabling. But that won't be fixed by surgery. That will be fixed by physiotherapy. And then your brain gets all these signals, and it's overwhelming for people. They get headaches. Fatigue is the absolute hallmark of endo, but also nausea, vomiting, hot and cold. There's a lot of central symptoms, and each of those pains have to be treated in a different way. So the surgery removes the triggers, but you would still have muscle pain unless you retrain those muscles. You may have bladder pain unless you desensitize the bladder and bowel. And there's various ways you can do that. Or, the central symptoms, again, we have some medications that can help, but other things like mindfulness or there are exercises. There's a lot of self-help things you can do for those various symptoms. And again, EndoZone, that was the second thing people wanted. And there's quite a few things there. I know there's a lot on Endometriosis Australia's website, but there's also other websites. And one of the things we've done is put those websites together in one place that people can then go to and be directed to places where they can get help quite quickly.
How do you actually go about recruiting and including patients in your research process?
So we have lots of different ways, although in the endometriosis field, a lot of people with endometriosis have been very frustrated with the lack of acknowledgement and the inability to have told their story, and they really want better outcomes for themselves, but also their friends and potentially their children, or, people are very motivated to help in the endometriosis community. And we've been very lucky. We've had great collaborations with Endometriosis Australia and funding support, which has been amazing, but also the other endometriosis organisations. And a lot of people feel very comfortable putting things on social media that doesn't oblige anyone. No one's captured to participate, but we find people are incredibly generous and very keen to help us move from that big black box that we were in the 90s to, this is a medical condition with these treatments, and this is what we have these diagnostics and better medical treatments. Because one of the biggest issues has been we've not been able to trial medications very well, because until you'd had some surgery, which is a pain trigger, and then treated your endo, because you'd normally do it at the same time, then we could actually put you on a trial. And, that didn't tell us whether the medication worked. And we certainly don't know if surgery is better than the medication, because we've never done those trials. So until you can actually get really good diagnostics, which we're getting, we can actually ask people who've had a scan that shows endo to trial 2 medications, or to try surgery versus medications. And we can start to actually work out what the best treatments are once we can actually undertake those trials, which in any other condition, that would have been happening 20 years ago. So we're only just starting to say, well, this drug might be better than this drug. And the really great thing, and so the other thing is, people have suddenly realized a lot of people have endometriosis because we're better at diagnosing it. So we're now getting a lot of new developments. So we actually have a clinical trials unit in Adelaide that we participate in, and we've done a lot of trials on new oral medications. So there's a lot of new GnRH antagonists, and one has actually been put on the market this month. That's a new oral medication instead of Zoladex. But we've also got new devices, so new coils and new other actual treatments, so that people have a choice. And if something doesn't suit them, now a lot of people with endometriosis are very keen to trial a new medication, partly because they've not found something that works for them. So we find that a lot of people put their hand up and are prepared to trial new medications. And we've got a new trial starting in Adelaide, probably in the next few months, for a new device. We did a lot of the GnRH antagonist work in Adelaide, so and it has been in other parts of Australia and also New Zealand, but that's now come to market, and that's really satisfying from where I was in the 90s to have done all that work at the beginning, and now to be able to say, look, we have a diagnostic, and now look, we're actually getting some good treatments that don't necessarily mean you have to have surgery, or if you have had surgery, and it's really important to recognise that for a lot of people, surgeries are really important treatment, but you also have other options if it's not a complete fix. And we never think we cure endo. We talk about managing the symptoms of endo, and each part as they come up, we manage. But now we've got some tools for it, and people are interested in developing those tools, and companies are as well.
What motivates you to stay in the endometriosis space when we know that funding for endo research is significantly less than other diseases?
I think the thing that motivates me the most is there's so much to be discovered compared to other things. And that's quite hard, because when you do go for a grant, other groups have got so much data and they know so much more, and it looks so much more professional. And we're saying, look, we're just wanting to do the initial study here. The only thing is, if you do that initial study, so much comes out of it. that because we're right at the beginning, we're kind of probably moving into the middle a bit. But it's just the outcomes are so significant. You sort of think, gosh, this poor person has been through 10 years of torture or lack of acknowledgement or, loneliness in a condition they've not had any explanation for or understood. And you can actually see someone go, oh, okay, now I understand why that was all so hard. It was, and it's probably that self-empowerment that really drives me for some of the people I see. And I think being a clinician, it makes it a little bit easier because I can actually see what a difference it makes for people. And I have people under my care that I met at 15 that were dropping out of school and finding it very hard to consider a work career, and we got there. We managed to keep the treatments going, and we supported them and helped them through to a point where they've met their partner and they've got their career pathway under control, and they've thought about their fertility and sometimes preserved it, and got to a life that is actually, you can see they're enjoying and having fun in. And part of it is just supporting people, a lot of that supporting people, but also we should be able to medically manage things better. And as we've got better, we're giving much better outcomes for people. So that's very satisfying.
And finally, what is your hope for endometriosis patients in the short and the long term?
So my hope, I mean, ideally it would be nice to think of something preventative. And, if you have endo, we've got some way of reducing the progression of pain symptoms and not getting that activation of the dorsal root ganglion and the central symptoms. And part of that's recognising it earlier and being able to put some prevention in. And also fertility is affected by endo as well. And again, we're finding that you can freeze eggs. You can freeze embryos, we're not, a lot of people have been really inappropriately advised at a very young age to go and get pregnant, where we don't have to say that anymore because our technologies in the fertility world have got better. And there was a study out of Queensland last year showing that if you knew about your endo before you had fertility treatment, you were much more likely to report a live birth and much less likely to have very high numbers of cycles. And, being able to get the right treatment, fertility treatment from the beginning, not, 40 to 60% of people with unexplained fertility problems have endo. It's just not been diagnosed. And then we don't, we guess our treatments if it's not diagnosed, where we can target those treatments and not have to do lots of cycles. We could, but also if someone's young with endo, we can freeze some eggs so that they, we know endo is associated with lower egg numbers. So there are lots of different things we can do to help people later in life if they want those choices. But also, we do have medications. We need to show that if we use them earlier, those pain complications won't get so severe, and the re-triggering of those pain pathways, if we can prevent that earlier on, I think a lot of those complications as well. So ultimately for me, it would be a preventative strategy. At the moment, we're at least working on a treatment strategy. And ultimately, it's just, you want, rather than endo being this part of your life and, the rest of it being this big, you want the endo to be this big and all the rest of the fun stuff to be the predominant thing you're doing. And it's just being able to get that balance changed. I do think with appropriate funding, and I think we worked on a wing and a prayer and we're making some progress with appropriate funding. We've just maybe been able to make leaps and bounds in the last 2 years. A lot of that research has come out of Australia. And the World Congress of Endo is being held. They had 600 abstracts, which is amazing. It was a tiny wee conference no one went to because no one knew anything about it, and now it's huge. But the vast majority of them, the biggest proportion were from Australia. And that has been because of the National Action Plan, the fact that Greg Hunt said sorry to all the people with endo, and the fact that funding has been provided, and we've made as much use of that as we possibly can. We don't waste a drop, because we've seen it when we didn't have anything and we were just on the skin of our teeth trying to get something to work. And it's amazing when it is appropriately funded, just how productive we can be. The seed funding we get from Endometriosis Australia allows us to leverage into bigger grants. So we could not have done Imagendo without getting that preliminary data that shows it was going to be a solid thing to invest in by the national group. But, it's also, I think things are changing. I think women's health, female researchers are now able to get funding they weren't before. And I think the lobbying that the endometriosis community has needed to do to be able to say, look, this is our story. And it was so taboo to talk about periods and pain, which is a normal biological fact. So the fact that can be a conversation people have has made such a difference, because no one realised the extent of the problem until people told their stories and we're prepared to go and take a risk with that. And that helps us so much. So, we have to thank the community groups that allow that to happen, and the way you advocate for this research and support it financially. It's massive.
Professor Louise Hull, thank you so much. That was really insightful. And I agree that something preventative would be a game changer for patients. We hope that the Imagendo research project continues its success, and we're so pleased to hear that Australian researchers submitted so many research abstracts. It's encouraging to hear that we have so many people working to help patients here and across the globe. Next up, I'd like to speak with you, Dr. Kate Tyson. Dr. Tyson, patients often report that they've had to see multiple doctors before finding the right person who actually understood endometriosis and had the qualifications to treat it. Now, there's lots of research and education offered to health professionals, but do you agree that there is a disconnect between the research and the understanding between the wider health professionals in the community about endo? Why are we still hearing that GPs and hospital emergency rooms are dismissing people?
Yeah, it's an excellent question, and something that is clinically relevant every day. So patients are seeing multiple healthcare professionals. Most patients have had an experience of telling a healthcare professional about their experience, about their symptoms, about their story, and having that dismissed when it is prevalent in the literature what the symptoms and signs are and can be, but it's not necessarily disseminated well amongst the medical community. And I think one of the challenges is the niche world of endometriosis currently. So it's a very complex disease that presents in a variety of different ways for different people. And so it really does require specialised care to be able to detect and treat all of the symptoms that patients come with, and to have the ability to validate those symptoms and explain where they come from and try to address them clinically. GPs are specialists in every medical condition, so I absolutely commend them in the work that they do, and I don't envy their position at all. But endometriosis can present in a complex variety of ways. Sometimes patients also can struggle to find the right wording because we don't yet have that vocabulary to explain well the symptoms patients are explaining. And so it's not just GPs, but also, nurses and emergency departments, lots of other places don't have the complex understanding of the symptoms patients can present with. And I think this is, we can talk about it forever, but the reflection of the long-standing historical neglect of women's health conditions overall, and a lack of understanding of how complicated the disease is. It's not just a pelvic disease, it's not just painful periods, but far more complicated than that. We know as well that integration of research into clinical practice takes well over 10 years. And it's only since, really 2018, and maybe even a touch later than that we've had really enough attention on endometriosis. And when I say enough, I mean that enough is never enough. So only the last 5 years that we've had more attention on endometriosis, and there's getting more and more information disseminated to the community. And a lot of that comes back to patients who are really being their own self-advocates and doing really well at progressing that translation of research into clinical practice.
Now, you're both a researcher and a leading laparoscopic surgery specialist for endometriosis, and in your spare time, you're also the director of the Julia Argyrou Endometriosis Centre, which operates out of Epworth in Victoria. Can you tell us a little bit about the centre and what trends you've noticed with patient care?
Absolutely, I'd love to. So the Julia Argyrou Endometriosis Centre at Epworth was founded based on philanthropy by the very generous Argyrou family, and then supported by multiple other donors along the way, and donations also from groups like Endometriosis Australia. And it was founded based on the Argyrou family experience of endometriosis care in Australia. And there's a line in a video from Julia Argyrou saying that they just can't accept that this is the way that care is for endometriosis in Australia, and they needed to do something about it. And so we sat down and looked at what the gaps in care were, or the gaps in need are. And this came down really to three things. The first was what I addressed in our previous question about the lack of understanding amongst the medical community of endometriosis. And so looking at really furthering education and advocacy amongst healthcare providers, but also patients, carers, consumers, everyone in the community about what endometriosis is and how it can affect people. The second obvious, very clear shortfall was the lack of research. And this is really good, clinically translatable research that's able to impact patients' lives here and now. Ultimately, the centre goal is to cure endometriosis, which I think, has been a goal of many endometriosis researchers for a very, very long time. And we're just a small part of the bigger picture of research in endometriosis, but certainly we're looking to do clinically impactful research. And the third component of care was the difficulty with system access and navigation. The difficulty with system access and navigation that patients with endometriosis suffer. Mm-hmm. So really that experience of, telling multiple specialists, multiple GPs, seeing multiple other different subspecialties, whether it's an orthopedic surgeon for your sore hip or, a rheumatologist for your sore back. And then finally, eventually, after lots of time, money, effort, reaching a specialist who can explain the symptoms. And so these three pillars we realised were what was most important to the centre. And we've put together a team of researchers and a nurse coordinator to help patients to get clinically relevant research, to further education and advocacy, and to help with system access and navigation for patients with suspected or known endometriosis. One of the barriers to care is needing a referral to see a specialist. And that's it's a really common experience. It's a really common story. Lots of patients that I see both publicly and privately will say, I first told my GP when I was 13 or 14 about my really heavy and painful periods. And now I'm 25 and I finally have a GP that, has acknowledged that, yes, it's a problem. And so taking away that barrier to care, patients can self-refer to the endometriosis nurse coordinator by the phone number that's on our website or through the email address. And that's for patients cared for or planning to be cared for by an Epworth gynaecologist. And that really takes away that barrier to explore the symptoms and see what pathways of care might be the most relevant. If we talk about the difference in trends in patient care, we're really seeing the centres in the young, so we've only been around for about 18 months. But in terms of patient care, that nurse coordinator role is really seeing an increase in empowerment from patients and really strong positive feedback. What we've implemented so far is quite simple. It's one person. We're currently recruiting a second. Listening to patients with often telehealth consultation and listening to their experience and helping them to navigate the system. If they do see a physiotherapist and don't find it helpful, they'll help them to navigate to perhaps someone more specialised with their particular problem. And the same for all of the specialties and allied health specialties. So that experience of patient has been so positive. And a lot of my patients through my private clinic see the nurse coordinator as well and have such good feedback of how they feel their symptoms have been validated after a long period of time. The 7.5 years delay of diagnosis. A lot of patients are really finding a really positive experience having someone listen to them and someone they can also call. My consultations typically last 45 minutes. It's a lot of information to share. I do write down a bit of a plan, and then they often will go back to her and say, she mentioned something about this, but I didn't manage to take it all on board. Able to unpack that a little bit for me. So that's often really useful as well.
Great. Now, we often hear that endometriosis patients need a multidisciplinary care team to help manage their endometriosis. But does anyone actually know what that means? You recently received a research grant from Endometriosis Australia, and as I understand it, you're aiming to dig into this idea of the multidisciplinary team and what it can mean both for patients and health professionals. Can you tell us a bit about the project and why you felt this was something that the endo community really needed?
I would love to tell you more about the project, and with great gratitude for the grant that we've received from Endometriosis Australia to be able to do this work through the Julia Argyrou Endometriosis Centre. So we always talk about multidisciplinary care for endometriosis, and that those care teams vary based on what the patient's primary problem is or primary complaint, and it can be multidisciplinary care for someone with complex disease requiring multiple surgeons like urologists or colorectal specialists, anaesthetists, pain specialists, or it can be other types of disease like complex pain conditions associated with endometriosis who maybe need a different group of allied health, a different group of associated specialists to help them with their care journey. And we've seen the evolution of multidisciplinary care and, a handful of clinics pop up that have been quite successful in managing patients, but there's been no plan of what should it look like? What do patients want? What do doctors want? What actually works? We don't actually have the answers to that question. And with the recent announcements of increased government funding for multidisciplinary clinics, we thought it was really important to clarify first before we go and disseminate or create all these clinics, really clarify what's important to consumers, first of all, their families, and for clinicians, what do they see actually works? And so we're undertaking a prospective qualitative study examining the consumers and healthcare's opinions about the way a multidisciplinary clinic should be set up. Our objective is then to create that clinic and then to assess the outcomes. So really look and see, have we achieved what we wanted to do? What are the patient outcomes? How do we measure them? And how do we improve models of care for patients with endometriosis longitudinally, rather than just saying, well, we think this works, let's set up this clinic and, hope for the best. Yeah, so really excited we're well underway with that study, and we've got some questionnaires currently going out to consumers, looking at what their feedback is, and then we'll be putting together a publication later in 2023.
Dr. Tyson, do you feel there is some inequity for patients across the country to be able to afford a multidisciplinary healthcare team? I know that everyone would love to be able to see their pelvic physio much more regularly, but the costs are just so high. How do you bridge that gap between what the research recommends and what patients can actually afford?
That really hits the nail on the head of the experience of a lot of patients with endometriosis requiring multidisciplinary care in Australia. And certainly the gap between metropolitan and regional is as wide for endometriosis as it is for any other health condition, if not wider. So certainly it's really, really prevalent. It's a common complaint for patients. Medically, we can do a lot of telehealth, but, for things like physiotherapy, you really do need that face-to-face engagement to be able to make improvements in pelvic floor dysfunction and also pain problems. If we look at how we bridge the gap between what's recommended and what patients can afford, we have to attack it from multiple ways. It's not going to be a single prong approach. I think the first thing is to really solidify further in the research and literature what the benefits of pelvic floor physio are, for example, and the other allied health things that are required. But physio is a really good example that we can use, for this story. Physiotherapists, qualified physiotherapists, there's a access shortage even in metropolitan Melbourne. There's long waiting lists to see qualified pelvic floor physiotherapists. So firstly, we need to look at how many people we have trained Australia-wide that are able to provide good quality pelvic floor physiotherapy, specifically for endometriosis. So if we cement that in the literature, then there'll be further weight added behind arguments for increasing rebates through Medicare, increasing access schemes like the Chronic Disease Management Plan, so patients can get rebates and can afford more sessions of physiotherapy. And then once we've solidified it in the literature and we've lobbied government even more so to increase the amount of funding that's available through Medicare, then getting those qualified practitioners out into regional communities is the further challenge. And I'm from the country myself. I have a decent working knowledge of lack of access to services in the country and how far patients have to travel for good quality care. One of the approaches we've done through the Endometriosis Centre with some patients has been having a relationship between a city physiotherapist who's, highly expert and a regional physiotherapist who has, a good working knowledge, but it's not maybe their kind of core business, setting up a relationship between these people so that they can see, their community physiotherapist with some kind of guidance and advice from someone more specialised in the city. And that's worked quite well for a handful of patients that we've managed to coordinate through the city. So schemes like that could be quite useful as well. But again, it has to be multi-pronged. We have to prove that it works. We have to show financially that it makes sense, from a government point of view. And from my point of view, a good pelvic floor physiotherapist will help keep patients out of hospital. It will reduce pain flares. It does reduce pain burden. It will increase productivity. We have to prove that before the government will give us any buy-in in terms of funding.
Dr. Tyson, how do you go about recruiting and including patients in your research process?
We have a fairly inclusive way of trying to include patients in research. So through the Julia Argyrou Endometriosis Centre at Epworth, patients can go to our microsite and can express their interest in research. From there, our research coordinator will look at their clinical picture and look at the research studies that we've currently got active and see if they're eligible for any of those, and then recruit them or refer them on to the person recruiting for that research project. So it's really interesting for people who, want to do more there. And that's really common in the endometriosis community, a really motivated and proactive group, really wanting to do more. And research is one of the ways that patients can offer that. In the private consulting suites of clinicians working with the Endometriosis Centre, there's also a QR code that patients can scan when they're seen by the gynaecologist, which can say, yes, I'm interested in research. And then thirdly, the clinicians can approach the patients directly. So for myself, I'm the lead investigator on a number of different studies. If I see a patient that I think is eligible, I'll say, if you're interested in research, there's this opportunity and this is, how it impacts you and the risks and benefits and how it may help the broader endometriosis community. Certainly, I haven't had any problems at all recruiting patients with endometriosis to assist with research projects. They've really, really, really been really proactive and engaged in research. Some of the studies that we're moving towards in the future is collecting specimens from patients with endometriosis who are having surgery. And of course, that's a little bit more detailed in the kind of consenting process and the questionnaire process. But patients, in my experience, have been really, really forthcoming with that information, and that allows us to do so much more groundbreaking research in furthering endometriosis studies. Patients want to do things. Often patients want to do things. They want to feel helpful. They want their experience to not be in vain. They want to improve the system. And so research is a way and easy access to research. And if the patient is currently not eligible for any of our studies, we do offer to keep them on our database. So if in the future, some of our future studies, they are eligible, we can then call them and say, are you interested in participating in this particular research?
What motivates you to stay in the endometriosis space when we know funding for endo research is significantly less than other diseases?
That's a question I haven't thought about much because it seemed like a no-brainer. Why would you leave? My motivation is more the patient experience, and that's reiterated every single day that I see patients. Every single day, it's that same experience of I've told X, Y, and Z people and was told it's nothing. Was told go and have a baby, was told just get pregnant, was told it's all in your head. Those stories happen every day. And I feel like the patients are maybe younger than they were previously. So I'm having, people who are 25, 26, 30, something like this with these kind of stories. But I still do have patients in their, late 30s and 40s, even early 50s saying, I've had these symptoms for 30 years and no one's ever told me that it could be this. And now you're saying that, it could potentially be all of these symptoms related to endometriosis. And so while that's the patient experience in the industry with the disease that you work with the most, I don't know how anyone could leave. I don't know how anyone could say there's something more impactful or, more satisfying as a clinician to address.
And finally, what is your hope for endometriosis patients in the short and the long term?
My hope for endometriosis patients in the short term is that they get the care that they need and that they get the validation of the experience that they've had, and then they get options for pathways or solutions for care that are suitable for them. So many patients can't tolerate lots of different components of care, and so we have to be flexible as healthcare providers in what we offer patients and the solutions that of how we can cater them to patient needs. So in the short term, I hope they have access to those things, and I also hope that they get excellent symptom resolution and adequate information to guide their long-term journey. So endometriosis it's not a quick fix disease. It's not a one surgery and off you go, or one medication and off you go. It's a life course disease, basically, until menopause. And so in the long term, I hope they've got enough education to, be able to address their disease or address their endometriosis with confidence and without fear.
Thank you so much, Dr. Kate Tyson. We can all agree that improved patient care and treatment options are critical, and we hope that this can be achieved for this generation and not just the next. I look so forward as a fellow Victorian to see the success of the Julia Argyrou Endometriosis Centre and its positive impact for patients as well. All right, now shifting away from the medical side of things just for a moment, I'd like to introduce to you our patient representative, Antara Mascarenas. Antara, thank you so much for joining us today. Now, you've been diagnosed with endometriosis and you went through the health system trying to find that diagnosis. Can you tell us a little bit about your experience and what it taught you?
Yeah, that's a great question. So I started realising I was having some issues really publicly. When I was in my teen years, I used to have pain every few months, but I went to Canberra as a graduate in the public service, and in my first week as a graduate, had extreme pain on day 5, came out of nowhere, and I collapsed. Taken to hospital in an ambulance. When I went to the hospital, the doctor actually didn't even mention endo. So he was very uncomfortable talking about periods. So I didn't leave the hospital any wiser, but I did get some really good suggestions for a GP and then a gynecologist. So I was on a good path to diagnosis, but I was young. I was in a stage of life where I was transitioning to a new city. I had no family there, and I just wanted to spend my money on things I enjoyed as a 25-year-old. So when the specialist said, it'd be $2,000 for surgery, so, I can work through this. I can just manage the pain. I wanted to spend $2,000 on travel at that stage of my life. So now in hindsight, I would have just done it. I would have gone through the process. I would have suffered through the pain, and I would have been able to manage the chronic pain much earlier in my life, and that would have created less issues just for my body in general and the nervous system. So, if there's anyone out there listening, I would sort of go through that diagnosis pathway as soon as you get into the medical system. I was away from my family. I was starting to make new friends. It was a great time in my life. And I think the diagnosis or the symptoms tend to come on when we're at a stage in our lives when we're either a teenager or we're in our 20s. When it's a really heavy thing to have to deal with. You just want to be a normal young person who's either studying or working, yet you have this really complex condition that you're learning about for the first time when you're going through this stage in life when you're quite young and naive. And it's a difficult time to be dealing with such a complex medical condition.
Thank you so much for sharing that with us. Now, we hear governments talk a lot about investing in health research, but it feels like endo is the forgotten cause when it comes to investing real money, particularly when it comes to seeing something like diabetes get hundreds of millions of dollars over the past 10 years. How does it feel to you to be an endo patient with such little funding coming through?
It doesn't seem like the levels of funding are commensurate with the amount of people that actually suffer from the condition. So, 1 in 9 is a lot. And the levels of funding don't seem to match that. So as a patient at the other end of the pipeline, when we go see a doctor, the small level of funding for research it's not clear that it filters through because of that lack of funding. And I think there are some really great people who are passionate about the subject who are doing it, some of them in their spare time. So I've got a physio who said to me that, they should spend the weekend with, a bunch of experts learning about it and sharing knowledge, but they're doing that in their spare time. They shouldn't have to. So again, it's kind of women learning about women's health on top of everything else in their lives. So it is disappointing. We had an election last year where women were a really powerful group of voters. So hopefully we'll see some change there.
Do you mind sharing with us if you've ever actually participated in an endo research study? And if not, what were some of the barriers that stopped you from participating?
No, I haven't. And I don't ever recall being contacted about it. I've gone through the hospital system. I've had my laparoscopy. I haven't been contacted about it. And maybe when I was sort of younger, less busy in life and work, maybe I would have done it. But I think at this point in time, the barriers for me would be time. It wouldn't be something, that I would be able to commit to. And I think that's something that a lot of women would face. Online surveys are a great way to catch people who can't physically get from A to B due to time reasons or other reasons. And I think the communication around what your involvement is going to, how it's going to contribute and why it's really important helps as well. So understanding where it fits in the pipeline and how it'll be used. And then you're like, okay, I'm actually, it's only so many minutes of my day and I'm actually going to be able to contribute and help people and help the research. So I think that, when you realise what it's for, we're all more willing to commit the time and effort to do it.
Antara, you're an ambassador for Endometriosis Australia. What motivates you to put your face to this cause and help advocate for patients?
It's a cause that's really important to me because it has been a big part of my life. It came on, when I was young, and so it has shaped my life and my experience and my level of resilience. So I really want to build awareness out there. I know a lot of people who are very informed about a lot of things, but they've never heard of endometriosis, women and men. And where I really want to make a difference is in the workplace. So it's something that, we can have a rough few days each month. And if your boss just knows about that and provides a supportive environment, it can make the world of difference. It's not something that you talk about at the water cooler. It's only something that you would share privately when you need the support. But knowing that you can do that and having a culture at work where you can do that is so important. And one of my bosses was amazing. I was having difficulty at the time. He knew what it was and he proactively said, why don't you work from home? Those 2 or 3 days a month where, you're having pain and discomfort. Why don't you do that? Because then you will just be better the rest of the month. You won't get sick the following week. You won't get a head cold the following week, which is what used to happen to me. And that was before COVID. That was before working from home was the norm. So that was something that really helped me. And I want managers out there in the workplace, whatever profession, to get a sense for what they can do to spot the signs and support their staff.
And finally, what's your hope for endometriosis patients in the short and the long term?
There are 3 things I hope for. The first is that it will be better understood. The second is that we have doctors who can help us across the board. And the third is that we have a quicker pathway to diagnosis and management.
Thank you so much for sharing all of that with us. I absolutely loved that, Antara. Short, sweet, and to the point. And it just goes to show that endometriosis patients really don't ask for very much. Once again, thank you for your time today. Now, next up, I would love to introduce Professor Caroline Gargett. Looking forward to discussing your research. Professor Gargett, as the Director of the National Stem Cell Foundation of Australia, can you tell us exactly what a stem cell is and why an endometriosis sufferer needs to know about it?
Stem cells really are a very important cells in the body. There's actually 2 types. There's a pluripotent stem cell, and they're really only present in embryo just before it implants, very short period of time. They can differentiate and produce any cell in the body. Then there's in the body, there are stem cells, we call them adult stem cells, and they're present pretty much now. They've found them in every organ or tissue. And they're important in endometriosis for a number of reasons. And firstly, I'll just define what they are. They are cells that can self-renew. This is a key property of a stem cell. It can produce an exact copy of itself. And this maintains a small pool of cells in the organ or the tissue that manages the growth and repair of that tissue really for the lifetime of the individual. So they're very important cells. There are not very many of them present. Not only can they self-renew or replace themselves, but they also then produce what we call daughter cells, and then they'd be granddaughter and great-great-great-granddaughter cells that gradually mature and become the functional cells of the tissue. So, and that's called differentiation. And in endometrium, we've discovered two types of stem cells. There's an epithelial progenitor cell, and that makes the glands of the endometrium. And the glands make secretions. And if an embryo implants, those secretions feed that embryo for about the first or up to nearly 12 weeks when the blood supply is developing in the placenta. So they're very important cells. And so we think that one or a couple of stem cells sort of look after a whole gland in the tissue. Then there's another type of stem cell called a mesenchymal stem cell in the endometrium, and we've found them now around the blood vessels. And so they regulate or look after that there's enough blood vessels in the endometrium, because this tissue grows every month very rapidly. And so it needs a blood supply and a rapidly developing one. And so the endometrial mesenchymal stem cells look after that aspect. And they also make stroma, which kind of supports the glands, which also have really the big function that we're looking at to look after the embryo at the beginning. So that's how they work. And I guess for women and people with endometriosis, the key thing is that the lesions, which are really like endometrial-like tissue growing elsewhere, we think they start from an endometrial stem cell, or both of them really, and only cells with those properties, the self-renewal and the ability to generate many cells, of the functional cells of the tissue, can actually start a growth of endometrial-like tissue somewhere else. Most cells cannot do this. Only really like a stem or a progenitor cell has that ability to do that. And so they need to then get to those places to initiate the lesions. And that's really what we're studying.
Thank you. Now, you led a multidisciplinary research project on endometriosis, which aims to determine the role of endometriosis risk genes in endometrial stem cells. We hear a lot about how endometriosis can run in families, and then others where only one family member is showing symptoms. Can you tell our patients and our audience a little about the project and what you have uncovered so far to date?
Okay, so this is a big project, and it's funded by the United States Department of Defense, and it's been a bit difficult because we've been doing this work during COVID. But really, what our thinking is, it's based on earlier work, and I might just introduce that and get to the hereditary part afterwards. But basically, once we discovered the endometrial stem cells and we'd worked out ways to purify them, and we determined their identity and where they were in endometrium, we then started to look at their role in endometriosis. And firstly, we looked to see that they were shed in menstrual fluid, and they are. And both types, the mesenchymal stem cell, a lot more than the epithelial progenitor cell. And then we looked in the peritoneal fluid, or in the pelvic cavity of women with endometriosis, and without too, but with endometriosis during their menstrual period on day 2 when they were having a laparoscopy. So we collected the menstrual fluid. So you can see that was quite a hard study. And we did find some stem progenitor cells in there, both types, certainly not a large number. They're around the area of about 200 per mil. And to get that in perspective, blood has the white blood cells in blood is about 5 to 10,000 per mil. All right. So this gives you an idea that there's much more. There's about getting close to 100,000, maybe 50 to 100,000 of these cells in menstrual fluid. So a small proportion get back into the peritoneal fluid and into the pelvic cavity we consider it by retrograde menstruation. So what we also found was what we found that in most women with endometriosis, but in that particular cycle, what we also found was that a very small proportion of women without endometriosis also got back into the peritoneal fluid, much less actually. If we look at the median, it's actually 0, but there's just a few. So we think there must be something else that's involved, and that's where the genetic, the endometriosis risk genes come from, the genetic part. And we thought that the endometriosis risk genes, which now they've discovered 42, that's just been published this week, and that's a lot of the work has been led by Grant Montgomery from UQ and in conjunction with a big overseas consortiums. So our thinking was that these risk genes or risk areas may affect the function of our stem progenitor cells, and they may confer on them an ability to actually adhere and grow in really what would be quite an adverse place, like in the pelvic cavity, to let them grow, because most cells just can't really grow anywhere. So that's what our thinking is. So with that funding from the Department of Defense, from the US, we've been looking at that work, and at the moment we're still in the middle of it, I can tell you, but basically what we've been doing is looking at the gene expression profile of individual cells. We take hysterectomy tissue because we want to get the cells in the basal layer. You know, I have to go back to when a woman menstruates, about 3/4 of the endometrium is shed in menstrual fluid, okay, and a little bit remains, and it's quite a raw surface, and it rapidly is covered with epithelium, and then it grows in the first half of the menstrual cycle, and estrogen drives that growth. And we think that it's affecting the stem progenitor cells, and then all the other cells, differentiating cells, are doing that growth. And it's that layer that's left behind, what we call the basalis layer, where we found the epithelial progenitor cells. And so that's why we have hysterectomy tissue to do our studies, because down in the basalis, we need to get that, and that doesn't we don't know. We don't know whether some of it's shed in the women with endometriosis, or whether those our incoherent endometrial progenitor cells are up in the functionalis that is shed. We're not quite sure about that. So that's why we do hysterectomy tissue. And what we've done is then we've used a way of sorting the cells, because we've got markers for them, and then because they're rare cells, we enrich them. And then we put them together with some of the mature cells, and then we're doing what we call single-cell RNA sequencing. So this is doing the gene profile of every single cell that we've got. So in the first part of the study, we've got 17,000 cells, okay, from 5 different women. And there we've looked at the profiles. We're starting to get more understanding about the epithelial progenitor cells and what they may or may not do from their gene profiles. And so once we've uncovered a bit more of that, which we still have to do, we will then be looking at their genetic risk score and seeing whether that alters some of the gene profile, and whether some of the genes that are expressed might enhance their ability to attach, for example. So the type of work that we're doing. And we're still really in the learning process. We've done a bit of work with menstrual fluid as well. And we've made organoids out of which are like mini glands, mini endometrial glands. And this is work we've done together with University of Queensland. And they've made organoids together with some stromal cells, endometrial stromal cells, where they know the genetic risk score. And then that too is still being investigated and being analysed, and they've done a lot of sequencing there as well. So they're big experiments. They generate masses of data, and we're going through and analysing that data and trying to make sense of it. So, and hopefully we'll come out with some really interesting findings.
Now, we all know you have an incredible resume of achievements and have been tirelessly working to unlock knowledge for identifying a cause of endometriosis. How will this help women and people with the disease?
Well, that's our whole goal. We've really got two areas that we want to focus on, and we've had to do a huge amount of work to get to those goals. We're getting much closer now. But our goals are that we would like to determine the cause of endometriosis, because we think if we can understand the cause of endometriosis, then you can start to target treatments to the cause. And so that they'll be much more tailored to the disease, and there'll be less side effects if we can find good treatments. And the second area that we're really interested in is that, you know, women and people with endometriosis, it takes so long for them to be diagnosed, 7 to 10 years. And there's not really a good non-invasive test or diagnostic that can detect all types of endometriosis. I mean, imaging is improving things now, but it can't detect it all. So we're really interested in using menstrual fluid as a diagnostic medium for non-invasively getting hold of endometrial tissue that's being shed into it, that perhaps we can use to, and also even the proteins and other things that might be in there that come from the endometrium that we could use to find a diagnostic. So they're the two big areas that we're working on to try and help women and people with endometriosis so that they're not suffering as they currently are.
How do you recruit and include patients in your research process?
Thank you for that question. We are increasingly using a patient input into our research. We've done it in a number of ways. We've built up connections over time. It takes time with endometriosis support groups, particularly in Melbourne here in Victoria, where we're located. We've got quite good terms with the support group here at the Epworth, and we interact with the patients and talk with them. But we also, the other thing we've tried to do too is I ran a public forum too a couple of years ago that was very successful, and a lot of people came. And so we've got a lot of people tapping into our website. There's a lot of information there on both what we're doing in our research and some background information too on endometriosis. But the big thing that we've started to do is to get to have more involvement of women is we're sending out an e-newsletter, a Hudson endometriosis e-newsletter. It comes out a couple of times, perhaps 3 or 4 times a year. We highlight in there some of the findings that we've got, so people know what we're doing. But also, it's really so that we're establishing relationships with women and people with endometriosis, so that we can actually start to get them involved in our actual design of our experiments, so that we're working towards doing that.
Professor Gargett, your research doesn't sound simple, and I imagine it takes years to complete, along with the challenges of securing significant funding. What motivates you to stay in the endometriosis space when we know funding for endo research is significantly less than other diseases? And at the same time, can you also tell us how the US Department of Defense came to fund your endometriosis research?
So what really motivates me is that I really enjoy the science of what we're doing. I find the endometrium incredibly fascinating, and also the concept of stem progenitor cells. But the other really big motivator is really, once I joined a department of obstetrics and gynecology at Monash, it was my first postdoctoral position. I had come from a completely different other field, like hematology, blood. And once I learned about how many women had endometriosis and how the concept of retrograde menstruation and how the endometrium functions, that really is one of the big driving forces. You know, these women are young, that they are at the prime of their life, and they really often cannot reach their full potential because they're held back by their disease. And I find that that's just really not good enough, and something needs to be done. So that's why I'm very keen and worked all this time to develop what we needed, all the tools and our knowledge on endometrial stem cells, so that we could make a difference in the long term in perhaps finding a treatment and finding a diagnostic. So that's really what the big driving force. Also, it's a challenging disorder. I quite like challenges. I don't mind doing things that are really hard, and doing difficult studies, and that's what we've been doing. It's a very complex disorder, and it's going to take quite a bit to tease out all the different, really probably subtypes of the disease, which may need different sorts of treatments, and things like that. So it's really, I find it a challenge, which I'm really like to get my teeth into. And secondly, really, importantly, we really need to do something for the women and people who have been suffering for so long, and really misunderstood for so long, fobbed off for far too long. Now, the other thing is the funding from the Department of Defence. Now, isn't it interesting, isn't it, that the Department of Defence in the US would be funding endometriosis research? Now, the Department of Defence in the US it supports a massive amount of research, and a lot of it is really to try and it's all associated with the Defence Force, but really the people who work in the Defence Force, and they get diseases. And my thinking is that they put in the grant I applied for, it was the first year they put down endometriosis as one of the categories or one of the diseases they were looking for funds for, or looking to fund. And I thought that the Defence Force would have a lot of young people and a lot of young women in it, who are either actively in the service or in the administration. No doubt they have been going to the Department of Defence's doctors, because they would have a medical service, absolutely for certain. They probably keep stats, and they probably got this massive surprise to find out how many had endometriosis. You know, when you've got 10 or 11% of women, you need to do something about it. And so I think that's why they put that down there. And we applied, and we were very lucky to get the grant. So that's how it is. And in actual fact, there's a publication I found on the Defence Force and women and people with endometriosis. So I think they just keep tabs on what's going on and want to look after their people.
And finally, what is your hope for endometriosis patients in both the short and the long term?
So probably then the short term will merge into the long term, really. But basically, we would really like to find a non-invasive diagnostic test for endometriosis. The short term thing to develop a bank of organoids that we can test on, and then in the long term to make it personalised, so individual women can have their organoids generated from menstrual fluid and then tested for the particular treatments that the gynecologist would like to prescribe.
Thank you so much, Professor Caroline Gargett. I agree, trying to find another way to diagnose endo that doesn't require the time and expensive surgery would be significant. I look so forward to seeing how your study progresses and the benefit it can provide to patients. And lastly, we'd like to hear from Dr. Brett McKinnon. Dr. McKinnon, you undertook your postdoctoral studies focusing on endometriosis and ovarian and endometrial cancer. What made you choose endometriosis research as an area you would specialise in?
So, to be completely honest, actually, when I started my postdoc, I'd never heard of endometriosis. I was young, I was keen to travel, and I got offered a position overseas, and it was in an endometriosis research lab. So I remember getting on the plane, not really knowing anything about this disease and just cramming as much as I could on the long haul flight. And, I remember thinking, this is just so complicated. I don't know how we're ever going to start researching this. But, when I got there, I was pretty lucky, actually, that the head of the maternity hospital where I was going to be working, he was an incredible surgeon and really passionate about finding solutions for endometriosis. So it was really through his commitment and dedication that helped me see, how much need there was for endometriosis research, and it really sparked my interest in doing it. And ever since then, from an intellectual curiosity point of view, there's just so much we don't know about endometriosis. There's just so many things we can research. So I'm still going however many years later.
Great. Now, your research established a relationship between endometriosis lesions, nerves, and pain, and how this interaction was mediated by inflammation. How significant was this finding, and how do you feel it has benefited patients?
What we were able to show really was that in certain cases, there were endometriotic lesions that were located quite close to peripheral nerves. And when we found these endometriosis-associated nerves, I guess we called them, it was more likely that the patient was reporting high levels of pain. And we started looking into this a little bit more, and we found that, around these endometriotic lesions, there was also high levels of inflammation. So we started investigating whether there was this sort of interaction between the lesions and the nerves. And what we could find was that once the nerves were exposed to this high level inflammation, they got sensitized. And what that meant was that it only took a little bit of activity to activate those nerves. So only little bits of stimulus was able to create greater pain. One of the things that was probably a little less appreciated in some of that work, but I think is quite interesting as well, was the fact that we also saw that nerves could release some substances that could then go on and affect the lesions. So there was this kind of reciprocal crosstalk between the two. And I think it was really significant in the sense that it was the first time there was a biological mechanism that would start to explain this sensitization of nerves. And we sort of see that in the clinics a lot more, that even after a long time, and even when lesions are removed, some women can still feel pain. And we think, there's still research to be done on this, but that the nervous system has undergone definite changes. And I think, it really highlights that need to get to endometriosis earlier, and, to understand the mechanisms that are going to create the pain before they create the pain. It was something that was known quite well, or between sufferers, but to actually see some biological relationship to that, I think was the first time to give it some real meaning as well.
Can you tell us a little bit more about the projects that you're working on now, Dr. McKinnon? What areas are you hoping to find answers to, and what kind of timelines are we talking about?
Yes, so for me, the overarching need, and I think the focus of all the work we do, it really revolves around trying to separate out the complexity of the disease. As many sufferers will attest to, endometriosis is so variable in the way the symptoms appear, how it responds to treatments, progression of the disease. Every patient experiences their own journey. So I think this makes treatment not only really difficult, but it also makes research really difficult, because essentially we're trying to lump together all of these similar and related but slightly different conditions, and then discover one cause for all of them. It's never really going to be like that, I think. So until we can separate out the complexity of the disease, identify various subtypes that exist, I think we're really going to struggle to make any more progress. And so some of the projects that we're working on to do that, we look at gene expression and protein expression profiles of endometriotic lesions, seeing if we can identify signatures that occur in certain patients and not in other patients that might identify these sort of subtypes. We do some environmental and lifestyle studies where we're trying to identify different clusters of symptoms that might occur with different patients. I guess, some of the interesting stuff that I think and more future-looking things, we're also trying to grow little endometrium in dishes, I guess, which are known as organoids. And if we can get these from the patient, we can then treat these organoids with different drugs under the understanding that different women are going to respond differently to different drugs, and hopefully be able to target the treatments to the women individually. There's quite a lot of work going on there. And as for timelines, I guess, how long's a piece of string, unfortunately? It's hard to know when we'll hit on the right answers. I think that's the bad news. But I think the good news is I think, though, we are making discoveries in this space. We're really starting to speed things up. And I think that really is down, and it's been driven by the hard work that's been done, by the patients and by the patient advocates as well, because just that increased awareness is making it much easier for studies to get done and to take these steps.
How important is co-design of research studies with patients? What value does it add to a project, and what's actually involved?
Yeah, I think this is a really important concept, actually. And it's something that, we as scientists probably don't take into account enough. I think the first point of view, the first point I'd make is really, it's important to consider what are the relevant questions to ask. We need really to be addressing the problems that need to be solved. And for this, we need input from patients. So, we could be in the lab and we could find something interesting or hear about a new technique and think, yeah, that's really cool. I can't wait to try that. But, while that has its place, definitely, you can end up down a rabbit hole and investigating things that really don't have much use or much translational value. These are important, but I think we don't need to keep our eye on the prize and really understand that we're trying to address problems that need solving. I think the other point on that's worth mentioning is it's important to remember when we design studies, it does come from a well-meaning place, but ultimately there's the potential that the data we're trying to collect may be impractical or may place a high burden on the patient. And, if this sort of thing happens, it can make both it difficult for the patients, they won't want to be involved, and the data that we can get out can be relatively useless as well. So this can really create limitations and waste time and money. And, we want to avoid that. And one of the key things to do that is to really engage with the patients and understand whether or not what we want to do is practical and whether it works.
So what do you think then are some of the biggest misconceptions around research? Is all research equal?
I think that's a really good question to ask, actually. And I think it really follows on from the last point we were talking about, is the design of the research can have a really big effect on the quality of the research. And, I think by definition, all research should be read with a critical eye. There's factors like study design, power, the way the results are interpreted. They're all going to make a difference to the quality of the study. I think one of the major misconceptions is that just because it's published, it must be true. If you look in the literature, there's many examples of competing theories and many data to support those theories both ways. But it's important to realise that the way the study's designed, the techniques that they use, and all of the work that goes into that can affect those. There's positives and negatives for every type of technique or analysis that might be used. So I think when you're looking at research, you really have to consider, the quality of the study that you're looking at.
So many patients have spent hours Googling endo, and we all know how much of a minefield Dr. Google can be. How can a patient then really tell what research is to be believed?
Yeah, it's a difficult question, actually. And it's difficult for us as researchers to know what's to be believed and what's not. I think one key factor, and one way to start, I guess, is to look for accredited professional bodies and start with the research that they've endorsed. These bodies may have already done a lot of the hard work for you and identified, with their expertise, what they think is the most relevant and pertinent research to be looking at. I think if you want to go a little bit deeper and look for your own research, I think that's still relevant. I think it's a good thing to be doing. Much of the research is publicly available these days, so there is access to it. One thing I would suggest if you wanted to do that is to look for where the original research comes from. Quite often, ideas and theories and interpretations just get slightly varied as time goes on and become dogma, and no one really knows why. And this is an area that sort of dogs endometriosis particularly. So I think if you can go back to find that original research, you're going to get the best information. And I do get too that this is difficult. So the other thing I would suggest is that, there are many good doctors out there, many clinicians that keep up with the latest research. And, we work with lots of them. And I think finding a doctor that really specialises and actively engages with the research is going to be a good start as well.
Now, we've all heard the term ethics approval, but what does it actually mean and what's involved?
Well, at the literal level, any research performed in an Australian institute is required to have ethical approval from a certified ethical review board before we do any work. And so as a researcher, we write a protocol document that details what we're going to request from the patient, what we'll do with the data or the samples that we collected, and how it's going to be stored and used in the future as well. So the ethical review board will usually have scientific experts, legal experts, members from the community, and these boards need to be certified by the NH and MRC and usually attached to major research institutions. Some of the areas I think that are really considered by the ethics boards that are worth discussing are things like informed consent. I think it's really important that patients properly understand what they're consenting to, that they should have been given written and verbal information about that. The privacy for patients, what sort of safeguards are we going to put in place to make sure that their data is collected and kept securely? And also the provenance of the samples and the data that's collected, that really anything that's going to be done with those samples has to be in line with what was originally asked for in the first place. So there's many other considerations that we also do putting into one of these protocol documents, and it actually can be quite a lengthy process. And, we usually consider it a pretty good milestone, actually, when we get the clearance and we can start the project. I think, again, it really can depend on what the project is. Some of the more tricky ones that might put a little bit of a burden on the patient are obviously going to go back and forth and can take, 6 months to a year to really get these through and have everyone agree that the project can be done appropriately and ethically. We can get some more simple ones too sometimes, but it's a major piece of work and it takes a lot of effort and a lot of thought from everybody involved really to get it approved.
I'd love to know what motivates you to stay in the endometriosis space when we know funding for endo research is significantly less than other diseases.
Yeah, I have to say it's a hard one to answer actually. Endometriosis research has been underfunded for a long time now, and it can be really deflating, to constantly be rejected for funding applications. We put a lot of work in just to develop these projects. And I think just in general, research funding is at levels where only 10% of research is being funded. So, when you think about it, only 1 out of 10 bits of jobs you do ever go anywhere. And, in the case of endometriosis, this is even less funding because, technically it's not a life-threatening disease, so it doesn't quite get the same level of funding support. So it is really difficult to know that, all this work that you've been doing, any progress you made just could stop. We just lose funding and that's it. We don't have jobs. We lose scientists, very talented scientists will go to other areas and start working on other researchers and other areas. But, in all of that, for me, I really do see the challenges in endometriosis. And I think from a research point of view, it's exciting that there's so much potential to make so much change. And that's something that keeps me coming back all the time and keeps me trying to get that funding. And so I think that's probably where my motivation is to stay in endometriosis, and we'll stay as long as we can.
And for our very final question of the day, what's your hope for endometriosis patients in the short and the long term?
In the short term, I think my main hope is there's just greater recognition of the consequences and the debilitating effects of endometriosis, how serious a condition it is. I think this is a really important step, not just for the sufferers of endometriosis, but also for those working in the field, because the more recognition there is, the more understanding is that we can get funding and we can keep going and we can keep doing the research. So, in the short term, I think that is a huge goal. I think the good news is that since the time I started, never having heard about it in Australia and learning about it overseas to where we are now, where the government does have a national action plan. There's increasing awareness at the community and GP levels, and there's articles in the paper regularly about endometriosis now. I think there has been a real increase in the engagement and the understanding of the disease. So I think the progress is real. I think in the long term, I'd like to see an understanding that the consequences of endometriosis, the treatment pathways, are all individual, that it's really a complex disease that requires a patient management pathway that's tailored for each individual. I think with the complexity of this disease, it's the only way we're really going to get real improvement for patients. And I think this has to be understood, that this individualized patient management has to start as early as possible before any of the long-term consequences are embedded.
Thank you so much, Dr. Brett McKinnon. You are absolutely right. It really does start with increasing recognition and understanding of the consequences of endometriosis and its seriousness. Now, we are on our way, but more can still be done. So once again, I would like to thank all of our panelists for joining us and sharing valuable knowledge and time today. It's clear that research is the key to unlocking and improving diagnostic and treatment options the community needs and deserves. Now, as you heard today, supporting research and getting involved if you can will significantly improve the quality and efficacy of the research for you, the patient. If you'd like to learn more about research projects currently seeking participants, please visit endometriosisaustralia.org and click on the research notice board, where you can find links to studies and the organisations that were mentioned by our panellists today. That now concludes the 2023 Endometriosis Australia Symposium for Endo March. Thank you so much for joining us. A special thank you once again to all of our donors. It's through donations from the public that Endometriosis Australia can bring you events like this one. Jump online, endometriosisaustralia.org, to find out more ways that you can learn about Endometriosis Australia and support the brilliant work that is being done. Until next year, stay curious, happy and healthy, and we look forward to meeting you again in 2024.